Good morning, everybody. How are you doing this morning? Is anybody here who is a little bit tired? No one is tired. Okay, wonderful, wonderful. Otherwise, I would have taken that as a positive sign. But if you're not tired, that's okay as well. Now, we're looking forward to another final day. And we have one of the highlights of this conference to look forward to as well. I'm very, very pleased to have you here, Kathleen. Kathleen Martin Ginis is a professor at the University of British Columbia. I really want to correct that because it wrongly says McMaster University in the program, and that is where you were until last year. But now you are in British Columbia, and you are a psychologist by training, and your area of expertise is in the field of physical activity amongst people with spinal cord injury. And that is also what your talk today is going to be about. And we're very, very curious to hear what you have to say. So welcome up to the stage. And you may greet her welcome with an applause.
Good morning. Good morning. One more time. Good morning. Thank you, Wolfram, for that very warm introduction. And thank you very much to the Noscos Organizing Committee for inviting me. It has been such a pleasure to be here for the past 3 days and to see the very high quality research that is coming from the Nordic countries. So thank you for that. As Wolfram said, I'm from the University of British Columbia, and some of you may be familiar with UBC as, we're missing my presentation. There we go. Some of you may be familiar with UBC as it's the home of I-Cord in Vancouver, but what you may not know is there is actually a second UBC campus in the Okanagan Valley, about 500 kilometers east of Vancouver, which is not so far in Canadian distances. And the Okanagan Valley is nestled in between the Canadian Rocky Mountains and the Canadian Cascade Mountains. So it is a very beautiful environment. This is a picture of our campus, the UBC Okanagan campus. And the Okanagan Valley is famous for its beautiful lakes, its incredible mountains, some truly lovely wines, and altogether that makes for a very pleasant place to live and to work. So I've been conducting spinal cord injury research since 1999, and the first research I conducted on spinal cord injury and physical activity was a randomized controlled trial that I conducted with Dr. Audrey Hicks at McMaster University. And in that trial, we brought people with spinal cord injury into our lab, and we asked them to exercise 2 times per week, to do aerobic training and strength training twice per week for 9 months. And at the end of that trial, we found that people in the exercise training condition had significantly greater improvements in fitness and psychological well-being compared to the control condition. Now, as that trial was winding up, I read a paper by Dr. James Rimmer, and Dr. Rimmer is one of my academic heroes. And in this paper, Dr. Rimmer argues that people with disabilities have been essentially ignored from health promotion initiatives and health promotion research. And he argues that greater research is needed in order to examine health promotion strategies in order to prevent chronic conditions in people with disabilities. Chronic conditions and secondary conditions including cardiovascular disease, diabetes, and obesity. And so this paper really got me thinking, what can I do to take exercise from in the lab and move it out into the SCI community? Now, the challenge to fulfilling my vision back then was that at the time, at least in Canada, we did not have any population-level data on physical activity participation rates for people living with spinal cord injury. And it gets very difficult to argue for money for health promotion and very difficult to conduct health promotion or physical activity promotion research unless you have good baseline benchmark population level data. So to try and address that issue, I initiated SHAPE-SCI, the study of health and activity in people with spinal cord injury. This was a 9-month epidemiological observational study of health and activity in the Canadian SCI population. We recruited 695 adults with a traumatic SCI who lived in the province of Ontario, Canada, and then we contacted them at baseline, 6 months, and 18 months over the telephone and administered a set of standardized questionnaires to assess their physical activity and their health and well-being. In addition, we had a sub-cohort of about 100 people who received home visits. We went into their home in order to conduct anthropometric assessments and to collect blood. Now, we've published over 30 studies from the SHAPE-SCI data set, but I think that some of our most poignant data is also our most basic data. So at the most basic level, we looked at physical activity levels in our sample of 695 Canadians. And we found that regardless of whether people had paraplegia or tetraplegia, 50% reported no leisure time physical activity whatsoever. Now, leisure time physical activity, or LTPA, I think that's probably a North American term, a North American concept. But what LTPA refers to is physical activity that people choose to do in their free time, such as sports and exercise. And the reason why we focus on LTPA is because LTPA is the one type of physical activity that has been shown to produce health and fitness benefits in people living with spinal cord injury. Now, of the 50% of our cohort that were doing at least some physical activity, we found that on average, they were doing about 12 minutes of moderate to heavy intensity activity each day. And moderate to heavy intensity activity is the intensity of activity you need to do in order to get those health and fitness benefits. But as you can see, there is tremendous variability in physical activity levels in people with SCI. We had some participants who were only doing maybe 4 to 5 minutes per day of moderate to heavy intensity activity, and then we had athletes in our sample who were doing 4 to 5 hours per day of moderate to heavy intensity activity. And our data aligned quite nicely, I think, with other large-scale data sets that have been gathered throughout Europe, showing again a 50% inactivity rate among people living with SCI. And the data also align nicely with data that have been collected by Rita van den Berg-Emens in the Netherlands. And Rita has conducted this study where she provided accelerometers to people with a wide range of chronic conditions. This is people with spinal cord injury here, and these are people with spina bifida. And up here is the reference category of able-bodied adults, and the purple bars are activity levels based on accelerometry. And what she shows in this study is that people living with spinal cord injury are at the very end of the physical activity spectrum, doing less activity than virtually every other type of people with other types of chronic conditions. We also looked at our data longitudinally, and what we found is that we could categorize people into 4 different categories based on their trajectories of physical activity participation. We found that approximately 1/3 of our participants were consistently active at all 3 measurement time points. Another 22% were consistently inactive across all 3 time points. We were pleasantly surprised that 14% of our participants spontaneously became active over the study. Remember, there was no intervention. This was purely an observational study. But what worries me most is this group. Nearly 1/3 of our participants were physically active at baseline and doing a reasonable amount of activity, but 18 months later, they were doing no physical activity whatsoever. And so what this tells me is that when we start thinking about physical activity promotion, we can't just focus on the 50% of people with spinal cord injury who aren't doing anything and focus on increasing their activity levels. We also need to keep an eye on the 50% of people who are doing at least some activity and make sure that supports are put in place to help them maintain their activity levels over the long term. So with this data in hand, in 2007, I established SCI Action Canada. So SCI Action Canada is a partnership between university-based researchers and community-based organizations who work together to advance physical activity participation among Canadians living with spinal cord injury. The grant for that initial upstart of SCI Action Canada finished in 2013, and I wrote a subsequent partnership grant where we can now look at these types of issues in people with other types of disabilities and look at other participation issues such as mobility and employment. But the SCI Action Canada brand lives on within the Canadian Disability Participation Project. And our mission at SCI Action Canada is to develop and mobilize evidence-informed strategies that inform, teach, and enable people living with spinal cord injury to initiate and maintain a physically active lifestyle. These are our partners. Currently, we are partners with 22 different organizations. These are organizations that provide services to people with spinal cord injury and other types of disabilities, organizations that promote sport and exercise to people with disabilities, and also organizations that have a vested interest in health promotion for all Canadians. And the way in which we work together is through something that I call a community engaged or an integrated knowledge translation approach. And what that means is that our partnership is committed not just to doing high quality research, but making sure that when we finish that research, that the results are put in the hands of the people who can use that research, whether that be consumers, clinicians, community organizations. And the way in which we do that is to involve both consumers, organizations, and university researchers in all of our projects. So what this diagram shows is that our partnership is at the heart of all of our activities. When we start thinking about a project, or even earlier on when we start thinking about writing a grant, the scientists and the community partners sit down together and they identify what is the research question, what do we want to learn from this project. Together we design the project and we carry out the research. When the research ends, we analyze the data, and then we sit down and we discuss how can we translate that data into products, tools, services that can then be implemented back into the community and put to use. Once the implementation happens, the research cycle begins again as we continue to monitor the implementation and try to adjust what we're doing in order to make it better. Our approach to developing communications and motivational interventions for physical activity in people with spinal cord injury has been very systematic. And the systematic approach that we've used has been guided by John Lewis's 5 key principles of effective knowledge translation. I've put the 5 principles up here, and for the rest of this presentation, what I'd like to do is to walk you through each of those 5 principles, giving you examples as to how we've applied those principles to develop our informational and behavioral interventions. So the first key principle is to know your audience and to know the issues. It gets really difficult to promote physical activity if you can't tell people why they should be doing it, if you can't tell them what the benefits will be if they are physically active. So it's been very reassuring to me over the past 15 years to see an accumulation of a body of evidence, both in my lab and conducted in other labs, but this body of evidence showing that there are significant physical, psychological, and social benefits of physical activity participation for people with SCI. And there's even some new emerging data coming from the US to suggest that there may be some financial benefits to physical activity as well. We've also spent a lot of time trying to identify modifiable determinants of physical activity, with our reasoning being if we can identify modifiable influences on physical activity, we can then develop strategies and influences in order to change those modifiable factors and increase physical activity. So this is an example of one of our studies in which we use Bandura's social cognitive theory in order to try and use a model of variables to predict physical activity. Now, Bandura's social cognitive theory suggests that barriers and facilitators such as social support, self-efficacy, outcome expectations, and self-regulation all predict motivated human behavior. In our model, predicting leisure time physical activity over a 2-week period in people with SCI, we found that the model explained nearly 40% of the variance, which is pretty good given how complex the behavior LTPA is and how difficult it is to predict in the SCI population. We also found that self-regulation was the only significant direct predictor of LTPA. Now, self-regulation refers to the strategies that people use to monitor and control their thoughts, their feelings, and behaviors. So it's things like goal setting, self-monitoring, action planning. When we found how strong a predictor self-regulation was in this model, that really cued us to start thinking about the need to ensure that we're teaching people self-regulation strategies and building self-regulation into our interventions. And I'll tell you more about that in coming slides. Another model that we've used to look at modifiable predictors is Schwarzer's Health Action Process Approach Model, or HAPA model for short. So in a nutshell, Schwarzer's model proposes that people can be categorized as pre-intenders, intenders, or actors with regards to a health behavior, and that people vary in their motivational readiness to change their health behaviors. So pre-intenders are people who have no intention whatsoever to be physically active. They don't want to think about it, they don't want to hear about it, they don't want to talk about it. Intenders are people who have formulated an intention. These people have good intentions to be active, but they haven't yet managed to translate that good intention into action. And actors are, of course, the people who are currently active. According to this model, if you want to get pre-intenders to become intenders, you must give them information or interventions to change these factors. Once they have an intention to be physically active, they cross this threshold, and then it's a matter of bolstering self-efficacy and using self-regulation to get them to translate their intention into action. In a study we conducted of over 200 people with spinal cord injury, we found that 25% had no intention to be active, didn't want to hear about it. And about 1/3 had good intentions to be active. They really wanted to be active, but they hadn't yet managed to translate those good intentions into action. And again, these data have been very important for us in terms of guiding our development of interventions that can influence people at each of the 3 stages of readiness to change. We also know that people with spinal cord injury face tremendous barriers to physical activity. Lack of accessible facilities, lack of equipment, lack of time. There have been many studies conducted showing the many barriers faced by people with SCI. So many studies, in fact, that last year we published a systematic review of review articles on barriers and facilitators to physical activity in children and adults with physical disabilities. We found 22 review articles on this topic, half of which included people with SCI. So I think the first takeaway message from this study is that we don't need any more studies of barriers to physical activity in people with spinal cord injury, at least not in children and young and middle-aged adults. We know what the barriers are. We need work to address those barriers. What we did in our paper, however, is that we organized all of the barriers from all of those papers into a social ecological model. What the social ecological model allows us to do is to look at where these barriers are situated. We see that many of the barriers, or some barriers, are situated within the person and in the person's social environment, but you see that for the majority of the barriers, they're situated in the institutional, community, and policy environments, meaning that we need a much more concentrated systems approach to addressing barriers to physical activity. We also coded the barriers as to whether they were barriers that could be potentially addressed by the healthcare sector, by the recreation sector, or by both. And we did this in response to another one of Jim Rimmer's papers, suggesting that there needs to be greater collaboration between the recreation sector and the healthcare sector in order to promote physical activity in people with disabilities. The second key principle of effective knowledge translation is to identify key messengers. That is, identify the people who should be delivering the information and delivering the behavioral intervention strategies. Earlier on in SCI Action Canada's history, we conducted several studies to try and figure out who do people with spinal cord injury want to get their physical activity information from. And not surprisingly, we found that healthcare professionals were identified as a highly valued and credible source of physical activity information, and all sorts of healthcare professionals, general practitioners, specialists, OTs, PTs, kinesiologists, all seen as very valuable. At the time when we conducted this research, it was a relatively new finding that people with SCI identified their peers as being a highly valued source of physical activity information. And I think this quote from one of our qualitative studies really sums up the reasoning behind that. Other people that have done the activity and can tell you from a person that is disabled what it's like to do that activity and what it involves, I mean, I think that speaks volumes to somebody with an injury to hear that. It is helpful. So having learned the value, the power of peer support and peer mentorship for physical activity promotion, we conducted several pilot studies to try to see if we could leverage that influence. These are data that come from our Active Homes project. So Active Homes was a project in which we took a fitness trainer and a person with paraplegia and sent them into the homes of study participants with paraplegia. So the fitness trainer went into the home and provided a personalized strength training program for the individual. And then the peer with paraplegia, they were there as well. They demonstrated the exercises and they provided some counseling to the individual on how to use self-regulation strategies to initiate and maintain their strength training program. And as you can see from this graph, when we followed up with our participants 4 weeks later, they were on average doing 3 times as much strength training as they were at baseline. In my lab, we do a lot of work right now on peer mentorship and the use of peer mentorship to promote physical activity. And in my larger research group, we have several ongoing projects involving peer mentorship. And I should say it was such a pleasure the past 2 days to see the amount of peer-based research that is going on in Noscos as well. And I want to show you 3 key things that we've learned so far from our research. First of all, in a systematic review we conducted, we showed that peer-delivered interventions are just as effective as professionally delivered interventions, and of course more effective than control interventions. We also did a study where we spoke to athletes involved in parasport or disabled sport, and when we asked them what was the biggest influence on you becoming involved in sport, the largest response or the most frequent response was hearing from a peer about sport and sport involvement. But of course, peer mentors do need training on how to promote physical activity, and we've run several pilot projects where we've taught, in very brief sessions, we've taught peer mentors how to do brief motivational interviewing and brief action planning, and we've shown that that very brief training can increase their confidence and their motivation to promote physical activity to their peers. The third principle of effective knowledge translation is to create audience-specific messages and practices. And over the past 10 years, we've created quite an array of informational brochures and videos and guides for people with SCI, and you can find them on our website. But today what I want to focus on are the SCI physical activity guidelines. So when we put this model together and identified key barriers, one of the things that surprised me was that at virtually every level of the social ecological model, we saw that a lack of information was a significant barrier. And that surprised me because if you Google physical activity and disability, you get literally 20 million hits. Literally, try it. It's a phenomenal number of hits. However, that made us wonder, well, there's a lot of information, but how is the quality of that information? So a couple of years ago, we undertook a review to look at the quality of Canadian information available on the internet with regards to physical activity and disability. We sourced nearly 100 brochures, information guides, and so on from the internet, and then we assessed them using benchmarks that the Journal of the American Medical Association has established for assessing the technical quality of online information, as well as some additional benchmarks that we thought were important. And as you can see from these data, there are very few online resources that are meeting those quality benchmarks, which I think really speaks to perhaps the lack of quality of many of the resources that are out there. I should also say that if you're trying to promote physical activity, it's really hard to get people active if you can't tell them what activities to do, for how long to do them, at what intensity, and how often. In the general population has had physical activity guidelines that provide that information for about 15 years. And in 2011, the World Health Organization and several industrialized nations worked together to harmonize their physical activity guidelines. So since 2011, we've had the WHO's physical activity guidelines, and most nations have a version of the guidelines that are quite similar to these. What these guidelines stipulate is that adults aged 18 to 64 should do at least 150 minutes of moderate intensity aerobic activity throughout the week, or at least 75 minutes of vigorous intensity aerobic activity throughout the week. And the guidelines also say that muscle strengthening activities should be done on 2 or more days per week. Now keep in mind these guidelines were developed for the general population. I would argue that there are at least 3 good reasons why we need SCI-specific physical activity guidelines as opposed to relying on the WHO guidelines. First of all, the evidence-based that was used to create the WHO guidelines did not include any studies whatsoever involving people with a spinal cord injury. Secondly, a rigorous clinical practice guideline should take into account the unique barriers, values, preferences, and needs of the people who are actually going to use that guideline. And of course, people with SCI were never consulted when the WHO guidelines were formulated. And third, a rigorous clinical practice guideline should weigh the values, or should weigh the benefits and the risks of adhering to that guideline. And personally, I worry about promoting a 150-minute per week physical activity guideline in a population where 50% do no activity whatsoever, and the other 50% do on average 12 minutes of activity per day. I worry about overuse injuries, overheating, and other types of injuries. It's something I think we really need to be concerned about. So in response to those concerns, in 2011, I led a Canadian team that developed the first evidence-based physical activity guidelines for adults with spinal cord injury. And these guidelines stipulate that for important fitness benefits, adults with a spinal cord injury should engage in at least 20 minutes of moderate to vigorous intensity aerobic activity 2 times per week, and strength training exercises 2 times per week, consisting of 3 sets of 8 to 10 reps of each exercise for each major muscle group. Now, since 2011, the guidelines have been translated into over a dozen languages. They've been viewed extensively and cited extensively, and I've been very pleased to see that they're used in some clinical rehab settings in various countries in North America, well, in Europe as well as in North America. But also since 2011, we've seen a tremendous increase in the volume of research on physical activity and spinal cord injury. So given the need to ensure that the guidelines are consistently aligned with the best available evidence, in 2016 I decided that it was time to update the guidelines. And I also was hopeful, given the increase in research, that we might be at the point where we could develop an exercise guideline to promote cardiometabolic health benefits. In 2011 there wasn't enough evidence to do that, but I was hopeful we might be able to do that now. And third, I wanted to engage international stakeholders in the guideline development process in order to maximize the likelihood of international dissemination of the guidelines. The process that we used to formulate the guidelines was the same in 2016 and 2011, and it is the same as the process used by the World Health Organization and other national organizations. And that's the AGREE process, or the appraisal of guidelines for research and evaluation. Now, what AGREE is, it's essentially a checklist that has 6 domains that you see on the left here, 6 domains with 26 items embedded in them. And these are key domains that need to be reported when you're developing a clinical practice guideline. AGREE evaluators, or people who evaluate clinical practice guidelines, they look for the reporting of that information, and they look to see that all of those steps have been followed in order to develop the guideline. And that in turn becomes a reflection of the rigor of the clinical practice guideline. So we follow AGREE, and we essentially use it as a step-by-step cookbook of how to develop a clinical practice guideline, or in this case, a physical activity guideline. The first step in the guideline development process was to conduct a systematic review of all available literature. So the inclusion criteria for our systematic review was physical activity interventions that were at least 2 weeks in duration, studies that included adults with chronic or acute SCI. We included studies with any design except for case study designs, and the studies had to have at least one measure of any of these outcomes. I should also mention that we conducted our systematic review in partnership with the SCI team. So our search identified nearly 21,000 abstracts. Once we passed them through all the inclusion-exclusion criteria, we ended up with 22 studies involving people with acute SCI and 189 studies involving people with chronic SCI. All of the studies were evaluated for risk of bias. We extracted key information. The evidence was then qualitatively synthesized and graded, and then we used those syntheses to formulate conclusions and guideline recommendations. So here's what we found. With regards to our first question, we wanted to know just in general, is exercise effective for improving each of these outcomes? And you'll note that I'm shifting my language from physical activity to exercise. The reason being, when we set out to do our systematic review, we wanted to capture all types of physical activity interventions, not just exercise, but lifestyle activity, sports, and so on. But the reality of the SCI research literature is that 99% of the studies involved structured exercise training interventions, and the other 1% were structured exercise training interventions plus sport. So we shifted our language because we thought it was important to be very accurate in terms of characterizing the literature, and the literature focuses on exercise, not on physical activity. All right, so first of all, looking at the body of research evidence involving people with acute SCI, we see that unfortunately we have very low confidence in the evidence supporting the idea that exercise can improve any of these outcomes. And that's simply because there is so little evidence involving people with acute SCI. There are only 22 studies, and that knowledge base has hardly grown since 2011. Looking at adults with chronic SCI and adults of any age, we see that we can have moderate confidence in the evidence supporting that exercise can improve all of these outcomes. However, when we look at young to middle-aged adults with chronic SCI, we were very pleased to see that we can have high confidence in the evidence showing that exercise does indeed improve each of these fitness and cardiometabolic health outcomes. And the difference from here to here is simply a reflection that so few studies include adults over the age of 65. The next question we wanted to answer was which exercise prescriptions are effective for improving the fitness and cardiometabolic health outcomes. What I'm showing you in this table, or I should say the way we approached this, was we identified exercise prescriptions that have led to significant improvements in these outcomes, but only for those types of exercise for which there were at least 2 high-quality studies. There were only 2 high-quality studies for upper body aerobic exercise and combined upper body aerobic plus resistance training exercise. There weren't 2 high-quality studies showing these outcomes for FES, for body weight support treadmill training, or other types of exercise interventions. For these 2 types of exercise modalities, we then extracted information on the range of prescriptions that have shown to be effective. What you see here are the range of prescriptions and also the AIS levels of participants who are in those studies. So here's where things start to get a little messy and a little complicated. We then graded the evidence for these exercise prescriptions. And what you'll see now is 2 patterns emerging here in the data. So with regards to the fitness outcomes, we see that we have moderate confidence in a body of evidence for people with all ASIA levels, suggesting that this range of exercise prescriptions can improve fitness outcomes. But we don't have evidence for this type of exercise for the cardiometabolic health outcomes. We do, however, have evidence for the cardiometabolic health outcomes for upper body exercise. However, we have low confidence in that exercise prescription owing to the fact that we don't have people with all ASIA levels represented in the evidence. So we took these results, we took this synthesis, and we passed it along to our stakeholder expert panels. We conducted 3 expert panel meetings, a European meeting, a Canadian meeting, and then a combined international meeting. And these meetings involved consumers, scientists, clinicians, and other stakeholders, and we were very pleased to have Nordic representation at our meeting. Dr. Jan Lexell participated in both our European and our international meeting. So the panels deliberated the evidence, and they made a recommendation, and at our international panel meeting, they formulated a final guide, two final guidelines. So I'm very pleased for the first time today outside of Canada to be presenting the International Scientific Exercise Guidelines for adults with spinal cord injury. So we have two guidelines. We have a fitness guideline. So this is a guideline for cardiorespiratory fitness and muscle strength benefits. Adults with a spinal cord injury should engage in at least 20 minutes of moderate to vigorous intensity aerobic exercise twice per week, and 3 sets of strength training exercises for each major functioning muscle group at a moderate to vigorous intensity twice per week. Does that sound familiar? Yes. So it is essentially identical to the 2011 guideline, however, with some minor changes in wording. So we were very pleased to see that the 2011 guideline was upheld, but with the most rigorous and most current evidence base. We were also very pleased that our panel was able to formulate a new cardiometabolic health guideline. For cardiometabolic health benefits, adults with an SCI are suggested to engage in at least 30 minutes of moderate to vigorous intensity aerobic exercise 3 times per week. And given that cardiometabolic diseases, such as cardiovascular disease, are a leading cause of death among people with spinal cord injury, we are thrilled to now have an exercise guideline that might help to promote health and to mitigate those diseases. So the vision for the exercise guidelines is that there will now be international adoption of the guidelines. But I want to stress that what you've seen today, this is the scientific version of the guidelines. The guidelines still need to be passed through a consumer engagement process to make sure that we're wording them accurately, and as the guidelines are pushed out throughout the world, that the guidelines are being interpreted and contextualized to the environments in which they are going to be used, both clinically and out in the community. I'd also like to create an online repository of informational resources that are created throughout the world to promote the guidelines, with the idea being that I think we can learn an awful lot from each other, from the resources that we're developing, and wouldn't it be great if there was one place where everybody could all find that information and share it with one another. And I'm also hopeful that with these international guidelines, we'll begin to see harmonization of the international promotion of physical activity to people living with SCI. The fourth key principle of effective knowledge translation is to select methods of delivery and implementation, and the fifth principle is to evaluate the effectiveness of those implementation strategies. We've recently conducted a qualitative metasynthesis in which we pulled together all of the qualitative studies we could find of people with disabilities who had been involved in a physical activity promoting intervention, and in which the researchers had asked them what worked, what made this intervention effective. When we synthesized that data, we found that participants said that effective interventions provided 3 things. First of all, evidence-based information on physical activity and how to manage their condition. Secondly, training on behavioral strategies to manage physical activity, such as the training of self-regulation skills. And third, social support from health and fitness professionals and peers. Now, there's lots of different ways you can build these components into an intervention. But a strategy that we've been using and developing in my lab for the past 15 years is physical activity counseling. And all that involves is having a trained professional who can be a peer, sit down with an individual and coach them on how to be physically active, to provide information on physical activity, to teach them some behavioral self-regulation skills. And the coaching can be done just once. But I think ideally, because physical activity is such a challenging behavior, I think it's important to provide the counseling over the long term to help people both initiate and maintain it. So we began our work in my lab on physical activity counseling back around 2002, I believe, and we began it with 2 randomized controlled trials. So in the first randomized controlled trial, we randomly assigned people with spinal cord injury to either an action planning condition or a control condition. Now, action planning is very simple. It involves asking people to open their calendar or open their diary, and then to plan out what days that week they are going to be active, what they're going to do, where they're going to do it, at what intensity, for how long, and with whom. We get people to put that in their diaries, and in this study, our control condition, we simply ask people to think about what activities might you want to do in the future. All of the counseling was done over the telephone, and we spoke with them every other week for 8 weeks. And what we found was at the end of the 8-week intervention period, the participants in the action planning condition were doing twice as much physical activity compared to participants in the control condition. We subsequently followed this up by seeing if we could get a further boost in physical activity by adding on coping planning to action planning. Now, coping planning involves thinking about barriers that you might face in the future when you're trying to carry out your action plan. Barriers like bad weather or not having enough time, and then planning what you will do when you face those barriers. The idea being is that when you do encounter those barriers, you already have a plan in mind for what to do, and it's easier to overcome them. And sure enough, these are baseline adjusted values. We saw at the 5-week and the 10-week follow-up that when people with spinal cord injury did coping plans and action plans, they were doing twice as much activity as people who were only formulating the action plans. When the randomized controlled trials ended, we worked with our partners to translate the RCTs into a community-based service where we provided ongoing telephone-based physical activity counseling to the SCI community. So this service was known as Get in Motion, and it operated from 2008 to 2016. And the idea behind it was that we had trained counselors who provided this counseling. We asked people to sign up for a 6-month counseling program so that we could be with them over the long term. And anyone in Canada with a spinal cord injury could call in and they could get this service for free. The Get in Motion program went through 3 cycles as we studied the implementation, tweaked the program, and then relaunched it. So what I'm showing you now are data from the 2nd iteration of Get in Motion. And when we looked at changes in our clients' leisure time physical activity, you can see that at the 6-month follow-up, we had significant improvements over baseline in the amount of strength training being done and the amount of total physical activity being performed. In this iteration of Get in Motion, we focused carefully on the implementation. We wanted to find out what are the key ingredients of the counseling that seem to be effective for changing people's physical activity levels. So our counselor kept very detailed notes and checklists on the amount of time he was speaking with clients and what he was talking about. So these are examples of the types of informational strategies that he used, giving people information on the guidelines, for example, directing them to resources online or in their community. And of course, we spend a lot of time teaching people self-regulation skills, such as goal setting, action planning, and coping planning. And what we found was that there was a significant positive correlation between the degree of increase in physical activity and the number of informational strategies discussed, the number of behavioral strategies discussed, the amount of time that the counselor spent with the client. And we also asked the client, how credible is the counselor? And the more credible the counselor was perceived, the greater the increases in physical activity. So this is important information because it highlights the key ingredients or the key components of interventions that we need to ensure are put into practice in our future interventions. So speaking of future interventions, one of my PhD students, Jasmine Ma, is now taking everything that we've learned about Get in Motion, and she's using that information to formulate a physical activity toolkit that physiotherapists can use to promote physical activity to their clients with SCI. This is a schematic that summarizes her nearly 4 years of dissertation projects. But the key thing here is that she has spoken to nearly 300 physiotherapists and people living with SCI in order to find out what they want in the toolkit. She's just finished conducting an RCT where she showed that the toolkit was effective in increasing physiotherapists' knowledge of physical activity for people with SCI and the use of behavioral strategies to increase physical activity. And she's right now in Vancouver collecting data in an RCT to look at how effective the toolkit is for increasing physical activity in people with SCI. Now, as we continue to move forward, I recognize we've been very focused on quantifying physical activity and increasing the number of people who are active and the amount of time that they spend on physical activity. But through the Canadian Disability Participation Project, we've decided that in addition to focusing on the quantity of participation, we also want to start focusing on the quality of participation. And last year, we published a paper as a result of a configurative review, where we identified 6 components that we think are very important to good quality participation experiences for people with disability. So these are experiential aspects of participation in virtually any domain, be it sport and exercise, employment. And these key themes are autonomy, belongingness, challenge, engagement, mastery, and meaning. So looking forward, one of the things we want to look at is our sport and exercise opportunities and programs that provide these experiences. Are they leading to more effective or more positive psychological outcomes and social outcomes, and perhaps even greater adherence? And right now we're actually collecting data to try and confirm the psychometric properties of a survey that will allow us to measure and assess these experiential aspects of participation. So as I wrap up, I'd like to leave you with 3 tips for communicating and motivating physical activity for adults with SCI. And I actually think these 3 tips can probably be applicable to virtually any type of health promotion initiative for adults with SCI. So number 1, use evidence-based SCI-specific information. This ensures that the unique barriers, values, preferences, and needs of people with SCI are captured in your initiatives, in your resources, and in your interventions. Number 2, teach self-regulation strategies. I would go so far as to say that there is now conclusive evidence that people who use self-regulation strategies are more likely to initiate and maintain an exercise program than people who do not use self-regulation strategies. We need to be teaching these self-regulation strategies. Number 3, provide opportunities for peer mentorship and peer support. I firmly believe that currently we are underutilizing peer mentors as a resource for delivering health promotion initiatives and for sharing information, and we need to do much better in leveraging the impact of peer support. And finally, to close out, I need to acknowledge that I'm just one person standing up here, but there is a small army of researchers and students and colleagues and community partners who are working with me on all of this research. Here is a list of past and former collaborators. I would also like to acknowledge the Canadian Disability Participation Project and our community partners and research partners in the CDPP, and my amazing graduate students who are back home in Kelowna, British Columbia. Thank you very much for your attention, and I look forward to answering your questions.
Thank you very, very much, Kathleen, for this fantastic overview over all the studies that you've done. And are there any questions to Kathleen? There's a question far away, up there. It's Finn.
Dad.
Thank you very much for an excellent lecture. Actually, I have several questions. You touched upon one of them, the age. And in our unit now, the average age of those who have a spinal cord lesion, either traumatic and non-traumatic, are 60 plus years. Another question is the setting. You talked about the barriers, facilitators. Will they be the same in Canada, where most of your research is based? I understand you have international also cooperation, but if I go to Africa or somewhere else, what then? And the third thing is, you also touch upon that, how to get it out when we talk about other areas, because nutrition is maybe also a very much integrated area in what we are talking about here?
Okay, that's a lot of questions. With regards to the age issue, yes, I still find it surprising that even though we are seeing this bimodal distribution now of age of injury, that older adults are still not being included in the exercise intervention studies. That's why, for example, I find it so exciting that Jan Lexell and Sophie Jurgensen are looking at physical activity in older adults, because we have virtually no data right now. The challenge for the future will be to include older adults in the exercise training studies. I see many exercise intervention studies for people with SCI where they include or they exclude people over the age of 65. And we need to address that. That needs to stop. Otherwise, we cannot have confidence that these guidelines apply to older adults. Your second question about barriers is an excellent one. And I do believe, I've traveled quite extensively and have been to rehab clinics and collaborated with colleagues throughout Europe and the UK. And I think in Northern Europe, Central Europe and in the UK, that our barriers are similar, also in Australia. But you're right, when we look at Africa, India, countries where the infrastructure is so lacking and just fundamental rehab is lacking in resources, I really can't speak to that. We haven't done any research on that, but we absolutely need to, especially if we're going to make these guidelines truly international guidelines. And your third question?
Nutrition.
Nutrition, yes, I get asked this question a lot. So I'm not an expert in nutrition, I'm an expert in physical activity behavior, and I have very good colleagues who work in nutrition. And what my hope is that the deliberate and stepwise approach we've taken to promoting physical activity, that others will take that and apply it to promoting nutrition and promoting other aspects of healthcare for people with SCI, bowel and bladder care, for example. I think a lot of these principles, for example, at the most basic level, realizing or recognizing that not everyone is ready to change their behavior. Just recognizing that can help us develop targeted interventions to address people's readiness and also to address the specific behaviors. Thank you. Oh, one more.
Thank you. And thank you, Kathleen. I have a question regarding body composition and the change after exercise studies. And you said that it were a low or moderate result in that. But I would like to know your opinion if the result in body composition is due to actually that people have better behavior concerning nutrition when they go into a study like that, or is it really due to the effect of training?
So just to clarify, we actually have high confidence in the evidence that exercise can change body composition, and that's captured under the cardiometabolic health outcomes. So it was moderate confidence for older adults or people of any age, but for younger and middle-aged adults with an SCI, chronic SCI, we can have high confidence in the evidence that exercise will change body composition.
Is that due to higher muscle mass level, or is it actually a decrease in fat mass?
It's hard to say. Some studies show both, increase in muscle mass, decrease in fat mass. We looked at all of the outcomes, and there is mixed evidence, but overall we see that body composition changes. And I think personally at the end of the day it depends on the type of exercise that you do as to whether you get the greater increase in strength or in muscle mass versus body fat loss.
Because I know it's difficult to, on the same time, actually control for food intake, and to do, because it's very costly and very complicated.
And very few studies have done that. I don't think any study has controlled for food intake in conjunction with an exercise intervention. They've added nutritional supplements, and we ended up excluding those studies. But I don't think out of all those studies I saw one single study that controlled for nutritional intake. It's a great question, and again, it needs to be done because nutrition and exercise go hand in hand.
Right.
Imagine what we might be able to accomplish if we were doing trials where both of those factors were addressed simultaneously.
Thank you.
Per Ratchkor from Linköping. I would just like to ask if there are any evidence or possibility to translate these this evidence towards the pediatric group with SCI?
Yeah, that's a good question as well. The challenge, as you know, in the pediatric population is, again, virtually no studies of exercise training in children. If we look at the guidelines in general for children in the general population, we see that children require a greater number of minutes per day of physical activity. So I would be reluctant to go out and say that these guidelines apply to children, first of all because of the lack of evidence specifically to SCI and what we know in the general population. So if you force me to say, I don't know. Probably no. Probably children need more activity. But again, something we absolutely need to be researching.
Right, we have time for one more question.
Gunnar Lindén, Rehab Station, Stockholm. I was wondering, have you seen any difference in improvement depending on if there has been a long time since the injury or a short time since the injury when people have started training? Well, I can summarize it to, is it never too late?
It's never too late. And I can say that from looking at the chronic SCI evidence, that the evidence includes people who are just 1 year post and people who are 20 or 30 years post. And the research evidence generalizes across all those years post-injury. So I think that's a fantastic message to finish on. It's never too late to start.
Thank you.
Thank you.
Thank you very much again, Kathleen, for sharing your great experience and all your results with us. Thank you for coming all the way from Canada. You did not only come for our sake, but mainly, I think. We're very, very happy that you came and would like to express this, sharing this little local gift with you again. Thank you very much.
Tack så mycket.
So, and now those of you that need a coffee have a possibility to get satisfied. Have another look at the exhibition, have another look at the posters as well. And then the parallel sessions for today will start in half an hour at 10:30.